On behalf of the Polis Center, I also welcome you this morning to SAVI Talks. I'm the Associate Director at the Polis Center, Sharon Candris. The SAVI Talks series has been put on by the Polis Center and its partners to bring together multiple sectors to discuss important community issues using data, and particularly through the lens of place. The Polis Center's motto is we bring things into perspective, and through SAVI, one of the nation's largest community information systems, we help organizations gain perspective through the use of data by understanding issues of concern and identifying strengths and building collaborative solutions. Today, our focus is on tobacco. This is an important public health issue that affects all of us, but for some, it impacts some people more than others. We're going to learn more about that today. So we're going to start off about learning what the data reveals to us in the findings, and then we're going to have a panel that comes up and has a conversation about the findings and about the larger issues around this. So I want to invite you all to join that conversation and ask good questions. Also invite you to join the conversation online at hashtag SAVI Talks. First, I want to take a moment to thank some of the partners that have made this event possible. Of course, WFYI, Gail, her team, and the Side Effects team. Really appreciate their ongoing partnership. And as Gail said, we just really value their partnership, and we value the way that WFYI just always brings a great perspective and thoughtful approach to important yet sensitive issues. I also want to thank the Richard Fairbanks School of Public Health, especially Paul Halverson. He's a national expert Indianapolis is very fortunate to have now, and we're grateful for his support in putting together this event and for sponsoring the event as well. And I also want to thank the Richard Fairbanks Foundation for its support of this event and many of the partners that are involved, including being one of the founding sponsors or sponsors of SAVI many years ago, and helping us to develop SAVI to support public health. In just a minute, Claire Fitty-Green is going to, the president and CEO of the foundation, is going to share a few words about today's topic of tobacco and how it impacts Hoosiers and what the foundation's role is in addressing this issue. Claire has joined the foundation in 2015 for the second time. Prior to this role, she served as a special assistant for education innovation to Indiana Governor Mike Pence, and she was co-founder of the Center for Education and Career Innovation. She also served as the founding executive director of the Indiana Charter School Board, a statewide charter school authorizing agency. And prior roles also included president of the Mind Trust, the grants officer for the Richard M. Fairbanks Foundation, and senior analyst within the Eli Lilly Company's corporate finance investment banking group. Please join me in welcoming Claire Fitty-Green.
Good morning, everyone. Thank you for joining us at 8 a.m. on a Thursday morning. Really appreciate it. Thank you to Sharon for that introduction, and thanks to the Polis Center and WFYI for asking me to be part of today's important conversation on tobacco. So welcome. I will spend the next 5 or so minutes talking to you about why we should care about tobacco and why we're talking about that today as kind of the backdrop and context for the unveiling of the report from the Polis Center and the panel discussion later on. And I'll talk briefly about the role that our foundation is playing and why we care so much about this issue. So let me start with some facts to set the stage for our conversation today about tobacco use in Indiana. The key takeaways that I want you to come away with is that our rate of tobacco use in Indiana is higher than the national average, and it is much higher for lower income populations. And that's important to remember when we hear more about the report and its findings and the panel conversation. So first, we rank 39th across the country for our adult smoking rate, which is a little over 20%. Much higher than the national average of about 15%. We also have much higher rates of pregnant women who smoke. It's 14.3% in Indiana, which is almost more than 80% than 7.8%, which is the national figure. The CDC, the Centers for Disease Control, just released a study a few weeks ago looking at youth use of tobacco, which is also important to remember for this conversation, and more than 7% of middle school students and 20% of high school students report tobacco use. And that's important because once you start, you're more likely to become a lifelong user and an addict. And then finally, according to the CDC, Hoosiers smoke at much higher rates when they come from lower income households. So families with incomes less than $15,000 have a smoking rate of 35.4%, and that decreases significantly as incomes rise. So households with more than $50,000 in annual income have a rate less than 12%. So you see a really stark difference there. So why should we care about this? Isn't this old news? What about the opioid epidemic, heroin? Shouldn't we care about that more? Well, we should care about that, of course, but I also want to make the case for why we should care just as much about tobacco. So the number one reason why we should care about tobacco is it's the leading cause of preventable death and a leading cause of disease in Indiana and the rest of the country and in fact the rest of the world. Here in Indiana, we have more than 11,000 Hoosiers who die every year because of tobacco, another 1,400 who die because of secondhand smoke exposure. So to put that into context, that would be like WFYI reporting every month that there were 2 fatal 747 airplane crashes. It's just a staggering amount of lives lost. And a moment ago, I talked about the opioid epidemic, which we also care about, and I know all of you do too. But right now, we have 10 times the number of people in Indiana who die because of tobacco than we do from drug overdose, and the leading cause of drug overdose is opioid abuse. And then diseases. Smoking causes 3 out of 10 cancer deaths and 3 out of 10 deaths from heart disease. So it is a real problem, and it has a significant human impact in Indiana. The second reason why we should care, if that doesn't move you, is how it impacts your pocketbook and our bottom line as a state. It is very costly to smoke for all of us, including the more than 80% of us who don't smoke. So a couple of data points I'll highlight here is that every household, regardless of whether you smoke, bears a state and federal tax burden of more than $900 every year. We just commissioned a study that was released earlier this year on the Medicaid population only, so just focusing on them. And what we found was, for the most recent fiscal year ending June of 2016, Hoosiers on Medicaid who smoke cost $540 million more in 1 year than Hoosiers on Medicaid who don't smoke. So there's just no question that it is not only devastating in terms of the human impact, but also the economic impact. And of course, this translates to employers. Employees who smoke cost $6,000 more a year than those who don't smoke, which is a drag on the bottom line for employers. And something that we've discovered, which I did not know before our foundation started working in tobacco, is that Indiana actually has a law on the books that protects smokers, so that we can't actually experiment with tools that would encourage them to quit smoking and get some help through their benefits plan at their place of employment. So the takeaways are that we have higher rates of tobacco use in Indiana than the national average. We have more lower income people smoking than higher income people. It has a significant impact on lives lost and then our pocketbooks and our economy. So what is the Richard M. Fairbanks Foundation doing to combat what I've heard referred to as the forgotten tobacco epidemic? A brief overview of our foundation. We were established by Richard M. Fairbanks, who was a longtime resident in Indianapolis. He owned a private communications company that operated, among other radio stations, WNAP, Naptown, and WIBC. He established his foundation to benefit the people of Indianapolis, and the mission is to advance the vitality of Indianapolis and the well-being of its people. We have 3 focus areas: education, health, and the vitality of Indianapolis, which we mostly define as the life sciences. So within health, and this is a change within the past few years, actually with the help of Dean Paul Halverson from the Fairbanks School of Public Health, was trying to really target what were the root causes of Indiana's embarrassing health statistics. We rank at or near the bottom of almost every indicator of healthy living and health. And tobacco was the #1 root cause as the leading cause of preventable death and disease. And then, of course, the opioid epidemic that we hear so much more about. So within tobacco, what we focus on are 4 strategies. The first is raising awareness of evidence-based policies. The good news is, because people have been smoking for so long, we have a lot of evidence and data about what works. And also we want to expand access to proven prevention and cessation programs. And cessation, of course, means to quit smoking. And then we want to make sure that people are remaining aware about this issue and also the solutions to help them either never start smoking or quit smoking. So we want to support the tobacco control advocacy infrastructure here in Indianapolis and the rest of the state. And then finally, we believe in supporting only those things that are proven or have good potential to be proven strategies. And so we are continuously assessing the data, commissioning research, and evaluating these policies and programs. I'll give you one example of a grant that we've awarded. We awarded a grant to the School of Public Health, and again, Dean Paul Halverson and his team were incredibly helpful. We released a report last fall, and the report did two things. It helped us understand the scope of the problem in Marion County and the rest of the state so that we could target our giving resources as effectively as possible. For example, that helped us to identify that there was a high rate of smoking in the Medicaid population. The second is it identified and just laid out what are the evidence-based policies and programs that can be implemented that would actually make a difference here in Indiana. And the report recommended a number of strategies. I'm going to highlight two of them, which again I think helps set the context for the conversation that we're going to have this morning. The first is that the most effective thing that we can do to prevent people from smoking and get them to quit is to raise the price, so the tax on cigarettes. And there's ample evidence that shows that every 10% increase in the price results in a 3 to 5% reduction in smoking rates. So it is the most effective tool that we can implement to control tobacco use. The second is to find other ways to restrict access to tobacco, especially for young people. The CDC reports that tobacco use is started and established mostly in adolescence, and that almost 90% of users actually started smoking before the age of 18, and almost 100% by the age of 26. So clearly, once you start, it's hard to quit, and then you become the lifelong addict that ends up as a statistic. And one other note there is that there are a lot of inventive products and ways to make tobacco more appealing to young people, like flavors, et cetera, that make it harder for young people to avoid the temptation, and once they start on a product, because they're more likely to try other tobacco products and become hooked and become an addict. So one of the policies that was outlined in the report was to raise the legal age to access tobacco to 21 from the current age of 18. And the reason for that is to make it harder for youth to purchase tobacco so that they don't become an addict. It also means that when you're 16 years old, you're less likely to have a 22-year-old friend, and so that if the age at 18, you can often find an 18-year-old or a 19-year-old to buy you tobacco, harder to find a 22-year-old. So it also changes the social norms and our culture around access to tobacco. So I invite you to learn more at our website. We publish a weekly blog. We continue to commission research, and we continue to make grants in tobacco. And just again, the highlights are that our tobacco use is higher than the national average. We have more lower income households smoking, and that matters a lot when we get to the retail density discussion. There are proven policies and programs that will make a difference, and we just have to come together and implement those so that we can make a big dent in our smoking rate in Indiana. So thank you very much.
All right. Thank you, Claire. Appreciate you setting that stage for us. Now I'm going to have the opportunity and pleasure to introduce my colleague, Karen Fredrickson-Comer. I've had the pleasure of working with and getting to know Karen for 18 years. And pretty soon I have to stop saying that year. She's someone that one of her titles is Director of Collaborative Research, and she is amazing at pulling together academic researchers and practitioners and really trying to tease out issues and understand what we can do about them. Her other part of her title is Health Geoinformatics, and there she's using advanced information technology, spatial technologies to understand issues of local, state, and national importance, and you'll see evidence of that today. I also admire, and she has a family. She's working full-time and is pursuing a PhD in public health or health policy and management from Richard Fairbanks School of Public Health. So she's a very amazing and warm person. She's caring. Something you won't find on her resume or her bio is that she has a long history of back in her history, I guess, in the important history of SAVI, she was one of those that helped lay a strong foundation so that it has become what it is today. So I want to ask you to join me in welcoming my friend and colleague, Karen Comer.
Thank you, Sharon. And thank you, everyone, for the opportunity today to share our SAVI research report with you. So, why are we talking tobacco? At our last health-focused SAVI Talks event in July 2016, we unveiled the SAVI research report called Worlds Apart. That previous report, which was led by, the research was led by Tess Weathers, who's in our audience today, I see, revealed that there are major gaps in life expectancy in Indianapolis, and depending on where in the city one lives. Someone living in a northeast suburb of Indianapolis can expect to live 14 years longer than someone living directly south of Monument Circle. We know that such gaps in life expectancy do not occur randomly. Genetics only play a partial role. Lifestyle is thought to play a large role, but social and environmental factors are important contributors to health as well. And these factors have an even greater potential impact than healthcare, and so they're worth examining. Variations in life expectancy, such as those that exist in Indianapolis, can be caused by differing socioeconomic, cultural, and environmental conditions. Some populations have greater access to health-promoting and health-protecting resources, for example, to adequate food, housing, and education. Conversely, others have greater access to or exposure to potential threats, for example, poor working conditions or poor water quality. One of our notable threats, health threats in Indiana, is tobacco. And as Claire mentioned, the September 2016 report on the tobacco epidemic in Marion County and Indiana, which was developed by the Richard M. Fairbanks School of Public Health for Fairbanks Foundation, provides strong evidence for why we should care about tobacco in our community and also what we can do about it. It was this report that spurred the SAVI team to look more closely at the tobacco environment in our city. As Claire mentioned, tobacco is a greater problem in Indiana and Marion County than in the country as a whole. As Claire mentioned, our smoking rate is over 20%, which puts Indiana in 39th place. And over 11,000 Hoosiers lose their lives each year because they smoke. And while smoking rates have fallen dramatically over the past 50 years, among vulnerable populations, such as those in poverty or with less education, the rate has fallen much less. And this gives us reason to examine potential social determinants of smoking. Although the harmful effects of tobacco are now widely known, the tobacco industry has retained its presence in the U.S. There are over 375,000 tobacco retailers in the U.S., and almost $8.5 billion is spent annually on health promotion. Much of this promotion occurs at tobacco retail sites because point of sale is one of the few remaining places that tobacco retailers have to target potential users. So examples include a display of information on sales prices or prominent in-store display of product placement. So research studies have shown that retail access to tobacco is associated with smoking initiation and with failed attempts to quit smoking. As such, tobacco retail density has become a measure of environmental health risk. A higher density of retail tobacco outlets can provide more opportunities to purchase tobacco and also increase exposure to point-of-sales marketing. Research in other cities has shown that the local density of tobacco retail outlets provides populations in poverty with greater access to tobacco products, and also the tobacco industry with greater access to those vulnerable population in terms of the point of sales marketing. So we were curious, what does the tobacco retail environment look like in the Indianapolis metropolitan area? We were wondering, are there notable differences in the socioeconomic characteristics of groups with high versus low access to tobacco retail outlets? So we collected locations of all certified tobacco retailers. We also have counts of births to mothers who smoke. We have socioeconomic and demographic population estimates from SAVI, and finally estimated smoking rates from CDC. So we learned that there are approximately 8,600 licensed tobacco retailers in Indiana and approximately 2,000 in Indianapolis. And we were interested in looking at three different factors about tobacco density and access. One, we were interested in where retailers were clustered. Also, we were interested in how easy it was to get to a retailer. And then finally, how near is one to a retailer at any given place. So the first two factors, retailer density and network density, account for individuals' ability to walk or drive to a nearby retailer, whereas the final measure, the accessibility, is where an individual may be exposed more often to the presence of tobacco retailers. So we combined these three different factors to develop a retail access score for each census tract in the Indy Metro area. We then clustered the tracts based on those access scores to find low, medium, and high access groups. So in this map of our results, the high access areas are depicted in the dark orange, medium access are in the medium orange, and then the low access in the beige. So this shows, we see that in the urban core, we've got higher access to tobacco than we do in the more suburban areas. So based on this grouping, that again is based off of the location of tobacco retail outlets, our next task was to compare the socio-demographic characteristics and health behaviors of these three different access groups. So we wanted to see how these three different access groups compared in terms of the population makeup and also health behaviors. So we found that maternal smoking is nearly twice as high in twice as high in high access areas than in low access areas. So in the high access areas, maternal smoking is 22.5%. Versus little over 12% in the low access areas. And it's notable that, it is twice, the rate of maternal smoking is in high access areas is 1.5 times higher than the maternal smoking rate in Indiana. So we're definitely have identified, or we're seeing a correspondence between high access areas and areas of high smoking. We also found that poverty is more than 3 times greater in high tobacco access areas. The poverty rates in high access areas was 34%, whereas it was just a little over 10% in the low access areas. In terms of education, high access areas also have 3 times more adults without high school diplomas than in the low access areas. So it was 23% compared to a little over 8%. Finally, the percentage of households without access to a vehicle is more than 4 times higher in the high access group. So we see that it was 4% in the low access and 18% in the high access. So residents in high access areas who may have more limited mobility may more often find themselves in close proximity to higher concentrations of tobacco retailers. And finally, The high tobacco access areas also had the highest percentage of people with color. The medium access areas also had a higher percentage compared to the low access group, almost twice as much. So mapping the tobacco access in the Indianapolis metropolitan area reveals that vulnerable populations have more retail access to tobacco than other segments of the population. And this provides information about where and about toward whom interventions and resources can be targeted. And as alluded to by Claire, there's been a wealth of research on what does and does not work in terms of tobacco control. The Institute of Medicine developed a national blueprint in 2007 that had over 40 recommendations relevant to federal, state, and local action. So here I've pulled out those just related to the state and local level. There's about 10 of the 40. And so some of the items that Claire mentioned, and that will be discussed later, are funding state tobacco control activities at the level recommended by CDC, increasing excise tax rates. There are recommendations for point of sale action, such as regulating retail point of sale of tobacco products, restricting the number of tobacco outlets, and limiting visual display of tobacco advertising. A recommendation that for the state level, as also to healthcare partners, is increasing demand for effective cessation programs. And at the local and state level, recommendations are banning smoking in all non-residential indoor locations, supporting the efforts of community coalitions to promote prevention and cessation programming, considering the populations that are disproportionately affected by tobacco when designing and implementing prevention programs, and ensuring health communications are culturally appropriate, and that special outreach efforts target all high risk populations. In other states, they are, some states like Rhode Island are restricting, our province anyway, are restricting price discounting. There's restrictions of pharmacy sales, restrictions of land use and point of sale advertising. There is a nonprofit group called Change Lab Solutions that is working with community organizations across the nation to help educate them on potential interventions and action that works. And what can be done here, our expert panel is going to talk about that. So I would like to thank now Paul Haverson from the Fairbanks School of Public Health, as well as Sue Hancock, for their expertise as we were pulling together the report and diving into this topic, and also for their expert review of the report. We'd also like to thank the Marion County Public Health Department for their expert review and feedback on the report. And finally, last but not least, I'd love to thank the SAVI data analysis team, including Kelly Davila, Deb Holland, and Matt Nolan for their work on the spatial analysis and visualization. So thank you very much.
Thank you very much, Karen. That was very insightful. Now we're going to move to a panel conversation. I just want to introduce our panelists, Carmel Roth. Carmel is the managing editor of Side Effects Media here at WFYI. Before joining WFYI, she earned a degree in English and journalism from IU, a master's in journalism from University of California, Berkeley. She's got a background in editing and managing national magazines, including a role as managing editor for Yoga Journal. She's focused on helping her team report and produce stories that make an impact on communities. And as I've gotten to know Carmel over the past few weeks, I've learned she is very passionate about using journalism to report on things that really make a difference. So please join me in welcoming Carmel.
Thank you. I'd like to invite our panelists to come up and take your seats here in the front, and then I will introduce you. also going to move a chair. Okay. Is this? Okay. Sorry, I was hoping to sit. The chair, is this on? Is this one on too? Okay, so our panelists are Brian Mills, right here. Brian is the president and CEO of the Community Health Network and the past chair of the Indiana Hospital Association, and he also is one of the founders of the Alliance for Healthier Indiana. Dr. Virginia Kane is the director of the Marion County Department of Public Health, and also an IU School of Medicine professor and a doctor. And Dean Paul Halverson is the founding dean of the Fairbanks School of Public Health at IU. Dr. Halverson was also the health commissioner in Arkansas in a previous life, so he's been in the field as well. So to start our panel, I wanted to ask each of you to just start us off by telling us why you got interested in tobacco and why it's an issue that you're here to speak with us about today. So we'll start with you.
Carmel, thanks, and thanks to everybody for being here and for all the research that's been done. My interest really comes through the Alliance, and I'll talk about that in a little bit, but it really is trying to find a way that we as a state can put aside competition, can put aside our individual beliefs, but really talk about the health of our citizens. And we know that this not only is death a factor, but so are other health issues. And when we talk about the cost of healthcare, which we're a contributor to, because that's what we do, we need to get on the other side of it and find ways to reduce the incidence of behaviors that not only are expensive, but more importantly, they impact people's lives.
Thanks. Dr. Kane?
Well, I first got interested in the smoking epidemic as a new health officer. We were challenged by the high infant mortality rates in our community. And when we looked at the smoking rates with our pregnant women, we were just honestly shocked. When we looked at white teenagers up to the age of 19, at least 58% of them were smoking back 15, 20 years ago. The other issue, anecdotally, is that on certain, some of the principals of some of the schools in a certain region of Marion County told us it was not unusual to see 10 and 12-year-olds smoking in the car as their parents are dropping them off. So like it was like a social norm. So that was just, it really caught our attention, and it contributed significantly to low birth rates. Our SIDS deaths were extremely high. And so that's really how I got very passionate about this subject.
Well, thanks, Carmel, for your leadership today, and thank you for leading us through this. I want to extend my thanks to the Richard M. Fairbanks Foundation, who actually started the ball rolling on this. I think their leadership as a foundation, in first of all, in establishing our School of Public Health, but then secondly, taking the time to really look at what really impacts health in Indiana, and specifically in Indianapolis, has really been important. For me, my interest in smoking actually, from an academic perspective, started as I learned about and got my doctorate in public health. And it was so clear, beyond the shadow of a doubt, that the leading cause of death in this country is related to tobacco. It is the leading cause of preventable death. And tobacco impacts nearly every disease, and frankly, tobacco makes just about every disease worse. But in a more personal way, I grew up in a smoking household. My dad smoked, my grandmother smoked. I had wonderful aunts and uncles that smoked. and I watched as a child relatives that I love die from tobacco-related diseases. And when I then added that together with what I heard and learned in public health, it became for me an important touchstone of why I came to public health in the first place. So. Great,
thank you. And for the next question I want to ask each of you is just an initial reaction to the research that Karen Comer presented here today. What stands out to you?
Me?
Yeah.
Well, it was one of those reports you read once and you say, wow, that's something you need to look at closer. Because while it made sense, I'd never seen that data. And then when you started looking at the national trends over 50 years and you started looking at the segments, it became very, very vivid what was going on. And then the other slide that we've shown and Paul's several times, which is the difference in life expected life based within central Indiana or Marion County over just a few miles. To me, that's still the core of all the things that we're trying to do. And
right,
when you
14 years difference.
Yeah, for 15 miles. And those types of numbers, and you add this to it and you start becoming more knowledgeable as to what's occurring. And part of knowledge is two things. One, you get your hands around it and you say, wow, I didn't know that. And then you say, okay, then how do you address it? What are the actions you can take to modify this for future generations? So I feel like we have a responsibility to use this data and do more than just report on it.
Dr. Kane?
Why, I thought this data was so powerful. And when I looked at the data, I think it really emphasized the impact of health literacy on communities and what their resources are. I'm an environmentalist, so you look to see where toxic waste plants are maybe located. You don't see that in suburbia, high-income places. Why is that? Because those communities have a significant amount of resources. They talk to their policymakers to say, hey, that's not going to be placed in my community. But when you go to areas that have very high poverty rates, economically, places that don't even have grocery stores in these areas, their health literacy is such that they may have difficulty accessing health care until the Affordable Care Act came along. Folks didn't have access to health care. So what does that mean? I don't have access to health education and promotion to tell me about things that are harmful and not. And so this are vulnerable populations who are being impacted because of the challenges they may have related to the low economics of anxiety type of things. They self-medicate themselves, so they're really vulnerable to what I consider that when you have this high concentration of tobacco outlets, it may be a predatory type of impact that we're seeing with these populations.
Yeah, I think it was mentioned in the SAVI report, and I also did a little other research. The tobacco industry specifically targets these neighborhoods. So it goes beyond the fact that there's a density of retail outlets, but they're also targeting these neighborhoods with advertising and marketing, and so.
The really scary part about this is when you look at the rates of smoking, especially in Marion County, the highest rates of smoking are in African American men. So when you have these vulnerable teenagers, our study in Marion County showed that of our 18 to 25-year-olds, 48% stated that in the past 30 days, more than 15 of those days, they felt they were in poor mental health. They couldn't even carry out normal activities. So what does that mean? That means they want to self-medicate themselves. So it's just like check cashing places. I need some money, but wow, the interest of those loans are like at 400, 500% higher than what you would see in suburbia. It's not fair to those young, vulnerable children to have frequent access and health promotion related to tobacco. Any place you go into, right front and center, they're exposed to that on a constant basis.
All right, thank you. And Dr. Halverson.
Well, I guess if my first reaction intellectually was to congratulate Karen, because this research actually is incredibly groundbreaking, because it does bring together a number of facts that we knew, but marries it with spatial data that I think really tells a story. So congratulations, Karen, to you and your team for a wonderful work product.
I already know your next study, but that's okay.
But my second reaction was I was madder than hell, because it created for us clear, in my view, evidence of the predatory practices of tobacco companies, and it further brought into pretty clear relief the task ahead. You know, people kind of wring their hands and they say, oh, we smoke. Well, yeah, we smoke. But the reality is, we know what to do about it. You know, this research is wonderful. But at the end of the day, we know how to actually bring this number down. And there are states that frankly have smoking rates that are half of ours. How did they do that? They basically said enough is enough. Let's implement practical policies that would restrict smoking and frankly do everybody a favor. And to me, it redoubled my interest and my focus on making sure that we try to do a better job, perhaps, of communicating the just absolutely urgent need to take action and to move forward in reducing this health threat to even our most vulnerable populations. So you picked a sore for me.
Great. The next question I was going to ask, I think, was touched on earlier, but you might want to add to it, Dr. Halverson. Just if you could give us a sense of what's at stake with the tobacco use, you know, not only in these specific communities, but in our state overall.
Yeah, so if we start, we'd look at almost 12,000 deaths. Just imagine, and Claire did a great job in the imagery, 2 747s a month that crash and everyone dies. And every seat's full, by the way, on that plane. Now imagine 12,000 caskets. It's just unbelievable. That happens every year, or 11,000, whatever. It's between 11 and 12,000. It's a lot of people. That's a lot of funerals. That's a lot of people that lose loved ones, and it's the leading cause of death. So you'd say, well, if we went to the death certificate, would we actually see tobacco as the cause? No. You'd see a whole lot of other diseases, cardiovascular diseases and diabetes and chronic obstructive pulmonary disease and a number of things. But the reality is this really is the protagonist to everything else. The other issue is it's about money. And sometimes, particularly when we talk with our policymakers, they say, well, you know, these are lifestyle choices. People are doing what they're going to do. Well, let's talk about $6 billion. That's a lot of money. I don't know about you, but to me, that's a lot of money. About half that's related to the healthcare costs. Another half of that's probably is related primarily to productivity loss. All of those things that actually take away jobs in our state and rob the average family over $980 in additional tax to each household in Indiana due to the costs related to tobacco use. So we know it costs a lot of money, and here's the thing I think that gets a lot of people, it certainly got me. For every pack of cigarettes sold, and this was in Claire's comments as well, $15.90 goes to health expenditures and lost productivity. So you sell a pack of cigarettes for around $6, and the state incurs a cost of almost $15.90. It's just, you're not going to make that up in volume. So the reality is we really have to think more broadly about if we really cared about the economy, if we cared about increasing the wealth of our citizens, if we cared really about the serious recruitment related to bringing in new companies, there is a strong linkage between tobacco rates and our healthcare expenditures. And so, again, all of these things suggest to me that at the end of the day, tobacco is both a really bad thing for our economy as well as for our health. And the other thing is, frankly, let's talk about well-being. You know, it's one thing to talk about people that are dying, but you know what's perhaps, and some would say worse than dying, are people who live a terrible life because they can't do what they want to do. They can't walk, they can't see, they can't get to the point where they can actually do the daily tasks of living. And so that quality of life that's taken away from people is in large part related to an addiction, frankly, which we know how to deal with and which we refuse to deal with.
Pause for applause. And Dr. Kane, I think it's zooming in more on Marion County. Can you talk a little bit about smoking-related illness and what you've been observing?
So one of the things that's probably the number one killer of cancer in Marion County is lung cancer. And as a result of our smoking rates, our incidence of lung cancer is 20% higher than the national average. And if we break our smoking rates down by demographics, we find that the African American male has about a 17% higher incidence rate, meaning 17% higher number of lung cancer rates, and it has a 20% higher mortality than their white counterparts. And so the frightening thing about lung cancer for us is that it's one of those cancers that even though we have the treatment, life expectancy is not that great in terms of cure rate. By the time you make the diagnosis of lung cancer, I'd say over 80% of them have metastasized. So that's the frightening news with this particular cancer. But I also want to highlight that Marion County is also recognized in the state of Indiana, probably number one for air pollution. So when you have industry that is putting out a lot of smoke and air pollutants in the air, that combination now almost triples the smoking rates and the secondhand smoke that we see in these vulnerable areas because you have a higher concentration of that industry in the inner city areas contributing to air pollution.
But it's not all bad news in Marion County.
Yes.
And so, and talking about policies that have been shown to work, you were going to tell us about a small reduction,
Yes.
large reduction, or small reduction in smoking rates?
Back in 2011, our overall smoking rate was 30%. Fast forward to 2015, we are at 21.8%, so we've seen a significant difference. We think we've had two smoking air ordinances, smoking bans, however you want to call it, that were passed. The first one not as comprehensive as our second one, which occurred in 2012, and we think it's made a significant difference. And I think there's been a recent study to show that our heart attacks dramatically were reduced, we feel, related to that smoking ban. But let me tell you, it took over 10 years to get the first smoking ban, and just incredible challenges and people not always keeping their promises of supporting this effort. So
What do you think, what did it take to really make that come together?
Well, I'll give you an example of one person, I won't mention his name, who, because he went to my church, so I feel I can talk about him, who was a city council person at that time. And we actually had initiated a anti-smoking initiative in our church with our members and everything. I see one of my other church members over there in the corner. So, you know, the pastor's behind it, and we're really pushing this. And the city council person said he was very supportive of this, but he got one of the food restaurant lobbyists got him just a few days before the vote that felt that they could be more supportive of, I guess, his political career. And so he said he was changing his votes. And unfortunately, my pastor was out of town. And but his sister-in-law goes to the same beauty shop with me. So
So one
I
of the
was
most industrious people.
I was able to track him down in California by cellular phone to say,
Yeah, there
hey,
you go.
you need to talk to your congressional person. You know, he's, you know, we need the Lord behind him. You know, he's got to, you know, come to Jesus discussion with him. And I'm happy to say he changed. He came back and finally supported the effort. We really needed that vote too.
Well, you know, Carmel, the other thing that's important to say is that although we have a clean indoor air law in Indiana, if you look at the industry actually that books conventions and so forth, we don't really get full credit for our law because it's known as one of the weakest laws in the United States. So we get to check the box that says we have it, but just barely. So one of the few things I think that can be done even with the preemption language is what Dr. Kane just mentioned, is the strengthening of indoor air laws at a county and city level. So I think that's a great testament to what could be done yet.
And Marion County has one of the stronger ones in the
Yes.
state, as I recall. You mentioned preemption laws, so I want to just bring up something I learned from research. With the SAVI research, you know, one of the things that Karen pointed out is the Institute of Medicine recommends possible regulation at point of sale, maybe to regulate advertising or discounting to make this tobacco retail less appealing or less targeting to vulnerable populations. In Indiana, that's impossible because of a law that was passed in 1997.
Yeah.
Saying that localities cannot pass their own regulations.
Strongly supported by the tobacco
Yeah.
lobbyists, by the way.
There's a researcher in California who's documented every step and turn of that, and you know there was a big fight. A lot of the anti-tobacco movement, you know, were working on it and trying to make sure it didn't happen. It was vetoed, and then the veto was overridden. English major. So, you know, that comes back to then what can be done if local laws can't necessarily be passed right now.
So isn't that frightening? I pay local taxes, and yet my state, and for my community and my resources, and it implies that I don't have the intelligence or the smarts to make decisions for my own community that I reside, despite the fact I do pay state taxes, but I pay local taxes. And so that's very concerning to me, that whatever we decide what's best for our community is prohibited by someone from the state who doesn't live in my area. They don't smoke the same smoke that I do. And so I'm very concerned that they're not really looking out to protect our interests on the local level. And it's what they don't even know they don't know that's scary, that I think I have a better expertise of knowing about my community and what their needs are than, say, someone that's not outside my community.
$280 million a year. Yeah, I agree. $280 million a year is what it's estimated that is spent by the tobacco companies in Indiana for marketing, plus hundreds of thousands of dollars that go to lobbying and political contributions. And I think that's the linkage between why we have the preemption laws, because it could hurt the tobacco marketing if, in fact, local communities could get together, like Dr. Kane just said, and make an intelligent decision. So it's a business interest issue, I think.
Turning to Brian Mills, you have been working with the Alliance for Healthier Indiana on something that you think you might get some political traction on, the tobacco tax. And I wanted to ask you to tell the story of how you got started in doing that work, and then, then I'll have a follow-up question.
Okay. Well, interesting. You get asked. We all get asked to do things that maybe you didn't raise your hand for, and I was asked to become the chair of the Indiana Hospital Association, and it's an honor, privilege. But I also believe that when you're placed in a position of leadership, you have influence, and you need to do something more than just conduct meetings. So it just so happened the day before I was placed into that position, the recent health status reports came out, or one of them, and it showed that Indiana was 41st. And you think about what we have here, especially from healthcare and big pharma and diagnostics and medical devices. I mean, it's a pretty amazing place, and large insurers.
It's our economy.
It is. And the B41st just didn't make any sense. So I took a flyer, and when I accepted the position, I stood in front of my peers and said, I would like, this information came out, I would like for us to take responsibility. I know we can't fix it on our own, but we can be conveners. We're the largest employer in most counties. We have influence throughout. And I would just I asked that my peers would let me know if they're willing to take the responsibility to convene. And instantaneously, I heard from my peers, 100 people around the state that said, yeah, you're right, we should quit looking at our shoes and try to do something about this. So at that point, I thought, oh my, now what have I done? So wasn't looking for another job, but you understand that your gut tells you that other people feel like you do, that it's embarrassing. It truly is embarrassing. And so I reached out to the State Medical Society. I reached out to Anthem. I reached Paul Halverson and I talked. Claire Fittian Green and I talked. I talked to the head of the Indiana Chamber, Indianapolis Chamber, over and over, and everybody said, yes, we're willing to do this. So we decided to convene. We didn't form another 501c3. We don't need one. We don't have any type of dues. There's no association. It's just, can we bring our collective wisdom together, and can we say, how do we improve the health of our citizens? And that's a daunting task. And then you start looking at data, like the data we're looking at today, and other data that's available. There's plenty of it out there. The problem is, any way you slice it and dice it, the best we are in anything in the country is 35th. That's our best. We go from 35th to 49th, and it's appalling. So we had a long conversation. Do you focus on infant mortality? Do you focus on obesity? Do you focus on childhood obesity? What do you do? And we decided that smoking, for a lot of reasons, was the right place to go. And part of the reason was something that Paul referred to, is the fact that there's so much evidence out there that says, how do you address it? That we don't have to go reinvent something. That we can just take this evidence, we can pull our coalition together, and we basically said that we're going to start with tobacco, not end with tobacco, start with tobacco, gain traction, go forward, and address a number of other crises that we have. And within tobacco, we said that the things we're going to do is that we were going to, one, raise the price, and Claire talked about it in her presentation, and we asked for a $1.50 per pack increase in price, because not that we were looking for revenue, the state's going to get the revenue. We were doing it just to drive down incidences, and so therefore you need to supplement that with our second one, which is additional dollars for cessation. Those dollars have been cut dramatically ever since the tobacco settlement. Third was interesting part, and it gets back into what you can do in a municipality. But that's the other thing. We also reached out to Matt Greller, who runs Accelerate Indiana's municipalities. So that's kind of the convener of all the towns and cities, and they immediately jumped in and said, absolutely, we need to do this. in there we said, hey, there's amazing research about the reduction in incidence when you do increase the age to 21, and this Tobacco 21 came. And so that was our third piece, and our fourth was again something that Claire talked about. I again ignorantly did not know that there was a regulation that has preferential treatment for smokers in the workplace. Had no idea. But I can tell you as a large employer, it ticks me off that I can't do something about that. And so when you put all those together, that's what we said we're going to go try to attack. And I'm just very proud of our group where we basically get together for lunch, and we have great conversations. We've had other people join us. I saw Jennifer Hurstabees from the Hospital Association. She and her team staff so much of what we do.
And you've been lobbying for some of these policies, or
And so
working
we started,
to promote them?
we got our introduction to lobbying 101. Didn't graduate, but we
Yeah, why don't you tell us what happened with your work to try to get the tobacco tax raised this last legislative session?
I mean, there were some wins. I mean, we did get it through the health on the House side. The Health Subcommittee 15, I mean, unanimously supported all four of the things I just mentioned, and that was fabulous. The tobacco tax was reduced to $1 per pack at the House level by the House leadership. It did not make it through the Senate, so none of this passed, except there was a slight, and I say slight modified, they would say 50% increase in cessation. Well, 50% was $2.5 million on something that we should have, 40 times that number. So there was some information, but however, I mean, I'm an optimist. This was never intended to be a one show event, and but we got awareness. We have a lot of people talking. I don't go anywhere now that I don't have business people and or legislators talking about what's going on, what's next, where are we going, et cetera. And we keep getting more and more data. So this is more ammunition for our fight. Because, and when you sit on the health care side of this, I see the impact every day.
And you said you pulled some, or maybe your partner, one of your partners, Anthem, I think, pulled some data for you to show really why the tobacco tax could be an effective tool.
Well,
Can
I
you
was
explain that?
testifying one day, and I won't say where I was or who asked me the question, but one of the legislators just said, so, I mean, Brian, healthcare costs never go down. So, don't tell me that this is going to result in a reduction of healthcare costs. And I was ashamed that I had not considered that question, so I wasn't prepared for it. But I walked out of there, and I talked to our Hospital Association staff as well as the Anthem people and said, okay, can you look at this data and see, is it relational? Is there data that shows that if in fact you have high rates of tax, you have low smoking rates, which results in lower lung cancer, lower heart disease? And I was right. And so I won't go through it all, but here's a little summary that I'll be glad to share. And if you take these are the worst, and these are the best on smoking rates. And if you look at that data, look at Indiana, and the Indiana data is pretty reflective of everybody else's. So we have the 14th lowest tobacco tax, 14th lowest. As a result, we have the 12th highest smoking rate. We have the 9th highest lung cancer rate and the 14th highest heart disease rate. So you take that data that appears to be linear, you get all this data and you look at it and you map it out, and it's not sequential, but it is definitely relational. And you understand that the research that said if in fact you use price as the major tool, it plays out in the data, and some of the data gets skewed about when were things implemented. But as you look at it, you say, no, there is a relation. And so as I have said in many places before, we just opened our 5th cancer center. And this 5th cancer center actually was a replacement center, and it's 3 times the size of the one it was replaced. And I'd be more than happy to put closed for business, no longer necessary signs in the front of them. I mean, we're not out looking to do this, and you would think we're out distributing these. We're not doing that. Mm-hmm. And it's very, very difficult to be in a position that you see it when it's too late. And if you get me into neonatal abstinence and things like that, which are indirectly related to all this, I mean, people just need to walk through and visually see what is happening every single day And we're going to keep on people to do that so that they understand this is not something we're making up for self-gain or personal gain.
Right.
We're doing this for the benefit of our citizens.
What do you think were some of the obstacles to getting that tax passed?
Well, I think there were a number of things. One, I do believe timing's everything. Okay, there's a lot of other issues going on. The legislature does not convene to hear us talk. You know, there's a bunch of other things going on. A lot of people shared to me, you know, don't be discouraged. It was just the wrong time. This was all about infrastructure. Also, as we know, what's going to happen in Washington, what's going to be the impact of the state. Will this could possibly be dollars for that? Can we tie it more to intent?
You mean the dollars could be used, if there was a tax, the dollars could be used for health care?
To continue the Healthy Indiana plan,
Mm-hmm.
to, you know, for something more focused on what we're doing versus it just being in the common fund. So
Right, I think I read the comment from a Senate leader saying, well, we just don't need the money right now from the tax.
So this is part of the problem, and frankly, I understand in Indiana, tax has a very negative connotation. I understand that.
They
It
feel like
doesn't-
they're having a heart attack and we need to get a defibrillator
Right.
out there to
But-
help resuscitate
But in
them.
this case, the tax is the intervention. The tax is the treatment. It really isn't about what you use the money for. It's really about raising the price of the product. If we raise the price, we can show a linear relationship with the reduction in smoking. And so in this case, I think that they just had such a hard time understanding it wasn't about the amount of money that they could use for whatever. It was really about raising the tax, which is the intervention itself. And I think that became the really difficult thing. By the way, I have a good idea. You know, Indiana is ranked 49th out of 50 in terms of our per capita funding for public health. If you want a good reason to raise the tax, I mean, we could certainly use money for public health, which focuses on protection and improvement of the people in the state. But I think they didn't get the connection that the tax really was the intervention. I don't know if
Well,
you
I think that's true. I also think that we got into a political realm where we're talking about health.
Right.
And they're only talking about
Money,
the
yeah.
money. And so while we were intentionally separating the two because we weren't looking for the money,
Right.
it kept being easily misconstrued.
Yeah.
And that's fine. We get to bat again.
And you also mentioned there was some significant lobbying against the tax.
Sure, we met a lot of new people. So there's no doubt that, and it was a tax for sure, but the other one was this whole idea of raising the age to 21. That really caught people off guard.
Was that in the same bill?
Mm-hmm.
I would say.
And that was a surprise to people. And I think it was one of those things that people didn't expect. And so they were trying to figure out what does that really mean. And also, I do believe that fundamentally, when you think about it, it actually can work. And
Which is what's so scary, I think,
Which
for
is
the
scary.
tobacco people. If you look at it, and Brian and I have talked about this, if you look at it, the Tobacco 21 initiative, we know that the tax will work immediately and beautifully, and it's got years to show. Likewise, there's increased evidence to show the impact, particularly long-term impact, on changing youth smoking patterns, which if you look at it from a long-term perspective, this is potentially one of the most devastating strategies to the tobacco companies, because we know that 95% of the people start smoking before they're 19. So the reality is, if we can prolong that so that they can't start smoking, and we know also, and I think Claire brought this up, there's a lot of 16-year-old kids that know 18-year-old kids. There are not too many 16-year-old kids that know a lot of 21 or 22-year-old kids. So we reduce dramatically that pipeline, and when we do that, we actually have the greatest likelihood of interrupting the whole supply chain and ultimately reducing the number of lifetime smokers, which I think that's the reason at the end of the day they're going to be most concerned, is because that particular piece of legislation has the greatest long-term impact on their product.
that has been passed in only 2 states. but get back to the municipality piece of it, it's been passed in many municipalities.
Hundreds.
And others are jumping into that. I mean, so the idea, back to what Dr. Kane was saying, that all of a sudden, oh wow, this can help me locally. So we want to do something locally. I think there's a huge opportunity for people at a local level to say, we don't want this. So let's talk about Tobacco 21 at a local level.
Which again, I believe is impossible
Right,
in
under
Indiana.
the preemption.
Currently.
I wouldn't say impossible, currently restricted.
Are the preemption laws something that your alliance might be looking at talking about with lawmakers?
I wouldn't go so far as to say that. I would just go so far to say that we're still trying to bring awareness to what the real issues are here. This is about life. This is about cost. This is about something more than just the taxation piece of it. And we're not going to give up on our cause. I don't know. I'm not going to sit here and talk about something that I don't know, how you get it done. I do think, however, by the actions throughout the country, that there is promise in addressing this in a different manner, which is really how do you eradicate it.
And coming back to local, Dr. Kane, I know your department has been doing some work in areas that you can. Do you want to talk to us a little bit about some of those initiatives?
So, we've got some great partners of our Smoke-Free Indy Coalition, and whether it's the American Heart Association, American Cancer Society, or even American Lung Association, and now our neighborhood association folks are getting fired up. I'm delighted to see one of them, Vicki Driver over there, who's in our health department is centered in inner city, Meadows area, high poverty, unemployment is kind of high. And it was refreshing to see a neighborhood association tackle, I think it was Dollar General, trying to add alcohol to their store. And they're saying, no, we're not going to have all these alcoholic retail density units in our community. And I think they actually protested and went on a strike and were very successful in their efforts. And so we need more partners like that, being aggressive. They're now we're going to take back our neighborhood because we're very concerned about our youth. We got to protect our adolescents. Surgeon General said that the electronic cigarettes is one of the most devastating things that can talk to teenagers. So we're trying to go into these areas now to have large apartment buildings that are smokers, trying to talk to them about making their facilities smoke-free. And we're having some successes related to that, to large apartment buildings. HUD made their facilities smoke-free 2 years before the law came out saying that they had to do it in 2016. We're also looking at convenience stores, trying to look at how they display their tobacco, and they're offering huge discounts. So when you come into the store and you got to pay for something, tobacco packages, very colorful, huge discounts for them to initiate them in smoking with our young teenagers. Moms sends their teenagers to go get stuff out of convenience stores. So that's who we're seeing a lot in the convenience stores. But we want to raise the age from 18 to 21 of who can smoke. If we can pull that off, that's significant. So we're working also on that effort.
Great. And I think it may be time to turn to audience questions. Can anyone give me a sign if we've reached that? Yes? Okay. So really appreciate everyone's comments. I just want to give the audience a chance to get their questions answered. Do you need, okay. So if anyone does have a question, raise your hand and we'll bring you a mic. And if not, I have more questions, but I wanted to make sure we leave time.
One of the things while we're waiting that I would want to amplify, frankly, is the reality of the tobacco master settlement. So as many people know, that the big tobacco companies actually settled with the states because of deceptive practices and other things related to tobacco, so each year over $300 million comes to Indiana. And as Brian said, up until recently, about $5 million was spent actually in tobacco prevention and cessation, which is the CDC recommended rate was $73 million. And so it's actually, I was reading an interesting quote by the tobacco companies, and they basically turned it around and said to legislators, you know, we're paying you hundreds of millions of dollars, and you're not spending it at all on what it was intended to. You said that the problem was that you had all these people smoking and you wanted to try to relate to reducing smoking. You're using it for other things. So why do you look to us as being the bad guy? Well, they are the bad guys still, but the reality is that we have the money. We're not using it for what it was intended.
Carmel, we have a question over here.
Is it possible or even advisable to have nicotine rated as a scheduled drug or even a legend drug?
Anyone want to take that?
Well, I mean, again, as a former health commissioner that had responsibility for scheduling drugs, that's always a sticky issue. And frankly, usually the state laws are pretty clear in delineating what goes in each of the classifications. Nicotine, in and of itself, has actually some medicinal purposes. It's nicotine overdosing and addiction it was never intended in that way, but you remember there's a lot of court cases that actually restrict the health authorities from regulating what's in tobacco. And so even if you were to schedule nicotine, which would be difficult to do because it does have other good uses, then you can't, it wouldn't work, frankly. I mean, it's an interesting strategy, but under the current legal framework, I don't think it would work in most states.
So I have a question about getting the message out to young people. I think Dr. Kane spoke about e-cigarettes, but there's also a thing of like hookahs and sort of these hookah restaurants. So how do we get the message out to young people that those are just as bad as smoking cigarettes, or, and you know, because it's more of a cultural and community thing, especially with hookah restaurants and things like that. So how do we get the message out that those are just as bad and you should probably shouldn't do that either?
So the trick is you honestly have to have resources to do it. You have to have a campaign. You have to have a message that resonates with teenagers, and you have to have them out there doing outreach to other peers about getting that message out. And we have to monitor the places that sell the tobacco to make sure that they're not selling to folks who are underage and they're asking the questions. But it is a really tough issue if you don't have the wraparound items to address social determinants. So, you know, I can talk about, I need you to concentrate on not smoking, but three days out of the week, I'm hungry, I'm starved, I got no food, I'm under stress. My mother says we may be kicked out because we're not sure we're going to have the rent. And so we've got to, you know, what kind of activity, physical activity that I can do to make me feel good. I'm not depressed. It can calm my anxiety. What kind of programs do we have for young youth to really get them involved with some things that will make them physically improve their well-being? And I think until we start addressing those kind of issues, it's going to be very tough to just try to fix that one piece void of all those other challenges that are facing them.
Good morning, and thank you for the program and for the panelists for raising the issue on tobacco here in our state of Indiana. If you, I just want to say a quick comment. If you're fired up about this issue and you want to be doing more at the state and local level, there are many partners in this room who are involved in tobacco control efforts. And so I just wanted to, if you don't know them, if the folks from Spoke for Indy just want to raise their hand really quickly, those who are working at the Marion County and Indianapolis level, and we do have other partners around other communities in the state of Indiana also engaged. So if you want to raise your quick hand, if you're one of our local coalition coordinators working at the local level as well. So again, if you're fired up and you want to be engaged more at that local level, find one of these folks as you leave today.
I wanted to highlight, while we're waiting for other questions, wanted to highlight some our maternal smoking rates in Marion County that's, I think, of interest. That when we look at our overall maternal smoking rates in Marion County, we're at 10. So that's lower than the state average, which I think was 14.5 overall smoking rates. But when we compared our white smoking rates overall in pregnant women, it was like 16. And our African American rate was 8.5. So African American women who are pregnant, the overall smoking rate is 8.5 compared to their white counterpart at 16. And guess who has the lowest? Are Hispanic mothers, who are off the charts less than 5 and closer to 2%. So that number goes up the longer they're in this country. They sometimes start adopting some of our American ways and whatever, but so they consider that's a new market. So use low rates with those African American women and the Hispanics. They're going to target them because it's a new market that are not smoking, and we've got to go after them.
We have one more question.
Yes, and I'm with the Marion County Public Health Department. I'm the community liaison for the health department. But I guess my question would be is, when do you guys plan, you have all this information, but when do you plan to take it out and give it to the neighborhood associations or give it to the public? Because working with the neighborhood associations and what they do, they can probably spread the word faster than you can, but just keeping it in a small area, not getting it back to them, because when they think about smoking, they think that smoking causes cancer. A lot of them don't realize that it relates to other diseases and other problems.
Can I ask Vicki to comment, if you don't mind? So Vicki, I'm going to ask you, you're the one as the president of your association, was it Oxford?
Yes.
Your neighborhood association. Can you stand up for us so people can kind of see you? So tell me, you're the ones, you may not want to be on camera showing that you tackled the alcohol issue at Dollar General. Is this something that your neighborhood association would be just as vigilant about with all these retail?
Yes, it would. When I was asked to come here, I was like, well, you really don't know too much about tobacco, but getting all the data and listening to all the information that was given here, it would be something that the associations and our neighborhoods need to know. Like Sonia was saying, it's so important to get information. And when you come to association meetings or meetings like this, you'd be surprised. At first, you're like, another meeting, but you'd be surprised of all the information that you get. And information is knowledge. You know, once you get it, you start thinking, wow, you know, that can affect me or my family. So in getting the word out to certain people, which associations, other organizations, spreading it out is amazing. You'll be surprised when you can get the people to come. So with us tackling the alcohol in Dollar General, we're in like a low income area, and it having alcohol when children were able to, or young adults are able to go into the store unsupervised, it just made them like, I can get this. I don't need anyone to go purchase it for me, or I could steal it or whatever. So we knew that we could not have that in our community. So tobacco, getting this information is making me really think, wow, that's another issue that, cigarettes are so easy for our youth to get, and we're tackling some of the service stations, or it's a law against selling single cigarettes. But some of the service stations are getting around that and still serving. You can go to a service station and get a cigarette for $0.25. So that's appealing to a kid. If you see somebody else smoking, you're like, oh, I can get Johnny to go in there and give me that. So yes, that will definitely be issue that the community and the associations would like to take on.
Carmel, if I could just add one thing. The issue related to community activation, I appreciated Miranda from the state who was responsible for tobacco cessation and prevention in Indiana, and I appreciate her leadership. But one of the things that the CDC has established is a list of evidence-based interventions that they would recommend that each state fund. How many of you have seen the TV commercials, the tips from former smokers? Have you all seen those? This is one of the most evidence-based strategies in terms of awareness, because we can draw a line when those commercials are on, and they are very graphic and they get you in the heart. But you know what that does? That drives people to call the quit line. So you can draw a line to when those ads are shown and when people call the quit line, and our ability, therefore, to attract people. That's one example of media. But working in neighborhood associations is another approved strategy by the CDC. In fact, they believe that grassroots activation in all of the communities is a crucial part of what needs to be invested in. And so as we think about a relatively poor, in fact, dirt poor tobacco prevention and cessation program in Indiana, there's not as much that could be done, but if we had more money, we could use it wisely to do exactly what you've mentioned, Dr. Kane, which is to get out to the neighborhood communities, to increase the evidence-based marketing efforts towards tobacco awareness. The average person tries to quit smoking 11 times. We can't quit on them. We need to help promote their initiation to start to quit again. So I think this is an excellent example of how and why we need to work towards increasing the funding and changing our policies.
Thanks. I think we have another question here.
Hi guys, Jeremy Smith from the Richard M. Fairbanks Foundation. You mentioned that $280 million is spent by the tobacco industry in Indiana alone on marketing efforts. How do we balance marketing that's specifically aimed at individual behavior change versus sort of public health, economic indicators that are impacted by tobacco use in Indiana? Can you kind of describe that meet in the middle maybe?
Well, I guess I have a hard time sort of differentiating those actually, because at the end of the day, if we are able to help people to change their mind about smoking, and that moves them to action to reduce smoking, that will have a profound impact on the costs related to medical care and so forth. So they're really inextricably linked in my view. I guess the issue around the funding of public health, again, I mentioned we're 49th out of 50 states on our per capita funding of public health. Part of what public health should be doing in this state, both at a local and a state level, is being very aggressive about awareness campaigns and treatment options and prevention strategies. Again, not to say that we're doing the best we can, but we just have a small fraction of what we need in order to be effective in this effort. So the money, I think, is all related together, and I'm sorry, maybe I didn't completely understand your question.
Well, I interpreted your question as saying, wow, we got $285 $300-some million with the lobbyist folks coming here, and yet we only have $7 million we have to fight this. And I just want to remind people that one person, just one person, can have an enormous impact in their community, influence. I think about the Mothers Against Drunken Drivers. One mother changed the landscape in this country because her daughter was killed by a drunken driver, and she mobilized folks. We look at Suman Coleman. You know, my sister died from breast cancer. So I am saying that if we engage our communities, get that message out, the information, we can be just as powerful forces. I would like the money, though. Because I think we could speed up the process, the more money and resources I have. Brian, I know you got the money for me. You know, hospitals are richly endowed and whatever. I keep talking to my sister, Hospital Ashkenazi, but I think I need to get out there a little bit, be more broad. But never forget the power of one.
That's true.
Combined with all of our efforts.
Thank you. And that was a great, I think, final thought. I think it's time for us to complete the event. And Sharon is going to join us for a moment up here. And thank you all for your comments.
I just want to say, as a panelist, I've appreciated the opportunity, WFYI for hosting this event, Fairbanks for helping to fund these studies, and we're just so grateful to have a School of Public Health here. You know, they do a lot of incredible work, and just thanks SAVI for having that rich data also as well. Just I can't say enough about how important health data is, and we've got to figure out a way how to continue to fund you. And I didn't tell your next study and whatever, if we could overlay your study with health outcomes, I think it'd be very, very powerful.
Yeah.
And whatever, so I'll look to see that next step from you.
Well, I think we will definitely look into that. I think that's a good segue to just some next steps. I think you guys have done a great job of outlining, like on a policy level, some of the legislative things and ways that we can help educate our legislators and folks. And we've identified some like kind of local area things that we can do, kind of creating awareness. And just wondering if anyone's kind of willing to step up and make a commitment to do something specific around, leaving here. Can you commit to doing something either within your community or within your organization to take a specific step towards creating awareness or doing something that you think will result in change? I know that there's going to be people that are doing some amazing stuff, and I think this is going to, and once people start thinking about all this information, that they'll start thinking about it. So I do encourage you to think about that.
Yeah. So one thing I didn't mention related to the smoking, and I should have from a health-related standpoint, is that we continue to have pediatric asthma cases, hospitalizations related to secondhand smoke. So that's really critical, and I know that we are working on funding a pediatric study and its impact from secondhand smoke and what we can do about it with the School of Public Health. So we're already doing that, but I may want to talk about funding, that next part of your study there, so please talk to us.
Yep.
Well, and Dr. Kane mentioned the public health, School of Public Health, and I appreciate it, but I also want to say how blessed we are to have someone like Dr. Kane as our health officer. I don't know how many of you live in Indianapolis, but she's our health officer, and I think she does a great job, so thank you so much. And also, I have to just shout out for Brian. Brian is the president of Community Health Network, but he's also very influential as a business leader in our community. And his leadership has been so incredibly important to the development of this alliance. And what's so neat about it is it's not just about the hospital association and all the organizations that are affiliated, but it's a very open thing to say, let's let everybody come in. Everybody that cares about this issue should be part of it. And his leadership, I think, has been so incredible. And I just want to say thanks, Brian, for all you've done.
And I'll echo that, Brian, Dr. Kane, Dr. Halverson, thank you so much for a good conversation. Carmel for leading a good, or facilitating a good conversation. Dr. Kane, thank you for your ongoing support of SAVI. We do appreciate that over the years, and it's because of folks like you that we're able to be here, have the data, do the things we do. And thank you to WFYI and Side Effects for their partnership, and Fairbanks Foundation as well. Want to let you know as you walk out, this is the report that Karen highlighted the findings from. So you're welcome to take those. There's a table in the back, and Elle's waving at you, and that's the side effects table. You can pick this up. You can also sign up for a newsletter up there for side effects. Also want to let you know, if you want to know about future events that SAVI offers like this, you can sign up for our newsletter. Go to savi.org, and you can sign up for newsletter there. Put a hold on your calendar for September 14th for our next topic, which will be on public transit. We're going to explore some ridership data, public transit ridership data, look at different rider types, how they utilize public transit, and how place plays into that picture. So it'll be an exciting topic, so hopefully you guys will be joining us for that as well. And I want to thank you all for coming today. It's a good conversation. You may notice we are ending a little bit early, and we're doing that on purpose because we want you to take the opportunity to connect with some of these folks that are in the room that may be able to offer ideas. Hopefully you'll take some time to get to know some others and make some connections as well. So thank you very much.